Hello, everyone. Hi, Jesse.
Hello. You guys can hear me okay, right?
Absolutely. And
Great.
hello, Miss Tricia. How are
Hi.
you?
I'm doing well, thank you.
Good, good. And thank you so much, Friva Freza, for joining us.
Yes.
We are the Stirrup Sisters, Nurse Jessie and I. And before we get started, we definitely want to put out a disclaimer here during this particular episode. We will be discussing some medical focused things, but we are not providing medical advice. Any questions that you may have, you definitely want to follow up with your licensed medical provider.
There you go. Thank you. Excellent.
Yes.
So, Nurse Christy, how are you doing?
I'm doing well. It's Thursday. The short week has got me sort of off kilter a little bit, but it's nice to have had the extra time to relax and not labor on Labor Day. But
Yes.
yeah, definitely doing well. How about
Yes.
you? You, Tricia and Jesse, how are you guys doing?
Doing well. It was a short week, and I still feel like it's only Tuesday, right? But I've done so much.
It's Thursday.
It's Thursday. But this month of September is a busy month
Yeah,
with cancer awareness.
absolutely.
And absolutely. And one in particular that we will talk about for today is ovarian cancer.
Yes, definitely a big topic. A lot of people, young as well as older folks, get diagnosed with ovarian cancer every single day. So bringing awareness to that is important. And to help us do that, we have our great friend at Optimum Pelvis, Miss Tricia, who's going to support us in our conversation today. And with that being said, I'd like to just take a few moments, Tricia, to have you introduce yourself to the audience and where they can find you as well.
So my name is Trish Sundberg. I am an occupational therapist specialized in pelvic floor therapy. I am in the greater Fort Lauderdale area, and my Instagram is Optimum Pelvis. That's my business account. And my personal account, which I just updated with a little more professional name, is trishsun.ot.
Wonderful. Wonderful. Well, I say at this point, let's just go ahead and dive into it.
Yes.
We've got about 30 minutes. So I'll kick it off to you, Jessie. Nurse Jessie, I know you've got some things.
I do. For our viewers and maybe viewers that don't really know what ovaries are, let's just give a brief,
Yes.
brief education on ovaries. Ovaries are the reproductive glands that are only found in women, female gender, and ovaries produce eggs for reproduction. Ovaries also are the main source for female hormones, which is the estrogen and progesterone. And quickly, what is the function of the ovaries? Just like I said, they produce eggs and they also give us the hormones, but the eggs that are produced will travel from the ovaries through the fallopian tubes into the uterus, where the fertilized egg, if it is fertilized, will settle and develop into a fetus. Just quick overview of what ovaries are.
Wonderful.
And we have one on each side
Yes.
of the uterus.
While you were describing that, I drew a very crude little picture for everybody. So a left ovary and a right ovary. And FYI, every month when you menstruate, you are releasing an egg from either or, right? I think that's important. And Nurse Jessie had mentioned the fertilization that doesn't happen by osmosis, that does happen via sperm. So We just want to make sure that we're being very, very clear in terms of the physiology aspect of that.
Absolutely.
So thank you for that lesson.
Yes. So now we can actually dive into what happens when the ovary become cancerous. Now, there's different factors. Some women are genetically predisposed to increase their risk for cancer, depending on genomic mutation. And other times it could be somatic, meaning it can happen over time within a woman's lifetime. But I do have some statistics from the American Cancer Society. And the American Cancer Society estimates for ovarian cancer in these United States of America for this year, 2023, about 19,710 women will receive a new diagnosis of ovarian cancer, of which about 13,270 women unfortunately will die from ovarian cancer.
A lot.
Mm-hmm.
So I think too, just really quick, to provide some color to this conversation, and you know, OT Tricia definitely jump in here as well. But you know, according to Mayo Clinic, there is not necessarily a cause for ovarian cancer. We don't know why that happens, right? And you know, Nurse Jessie, you had mentioned the types. So there's epithelial, there's somatic, and then there's also I'm sorry, not somatic, but stromal,
Right.
and then there's the germline, right? But the most common that we tend to see that it's diagnosed is the epithelial.
Correct.
And some of the risk factors include when you started your period, when you went into menopause. So the earlier you are in terms of starting menses or when menarche occurred, as well as once menopause occurred. If that happened earlier on, maybe in your 40s versus in your 50s, that puts you at greater risk. Not having a baby also puts you at greater risk.
That's
right?
the
So
nulliparity is
yes,
the term, but
exactly.
absolutely
That's the
not
clinical
having
term.
a baby.
Yeah,
Mm-hmm.
no Paris. But I think it's important that our listeners understand that even if you do not have a familial history in terms of ovarian cancer, there are other things that play that can lead to a diagnosis. So that being said, I think it would be great for us to kind of go into what are some signs and symptoms that folks should be looking out for, and when should you reach out to a licensed medical provider to have a conversation, because there are some signs and symptoms where an individual might say, oh, you know what, I'm just bloated, no big deal.
Right.
Well,
Right.
it could be a big deal.
Right.
We don't know. But I think that's important too. And then, OT Tricia, for you to run down some of the things that you also see in clinical practice, for sure, would be helpful.
Yeah. So for me, I mean, on the therapy side, it's what happens after, you know, what happens after treatment would be more my expertise. So when women are having, you know, different surgeries, the thing is, post-treatment, they don't really talk about the therapies that are out there. They don't really talk about the help or the resources that are out there, if you will. And so pelvic floor therapy is kind of like going under the radar. A lot of women, you want to talk about issues that they have without having, you know, any diagnosis. Nobody really wants to talk about it because there's a big stigma. So then when something does happen, you know, it can exacerbate things like urinary incontinence, things like fecal incontinence, sexual dysfunction, and nobody really wants to talk about it, even pelvic pain. And because there's such a stigma, and because, you know, it's the below the belt health, it puts women like in a vulnerable state, kind of to
Sure.
ask for that help.
Yeah.
So,
Yeah.
so as an OT, you know, it's not just the physical things that we focus on too. It's also, I think, when women go through cancer treatment, it's very traumatic
Yeah.
and very stressful. And so as an OT, my approach is a very biopsychosocial approach. So I focus on, nervous downregulation of the nervous system, focusing on, sometimes we have to do meditation, sometimes we have to just sit with ourselves, do some body scanning, really focusing on what is happening. And sometimes, there's such a disconnect between the mind and what's happening in the body. So like you mentioned, what symptoms are you really feeling? Where is the pain? Is it internal? Is it external? What's really happening? So as an OT, that's what happens during evaluation. We figure out what's going on. We figure out where the pain is happening. We figure out how we can kind of de-stress the mind so that we can focus on everything that's going on internally. It's like a holistic approach, if you will.
I love that. And so just to bounce back a little bit, when you talk about the stigma, right, that's associated with not just ovarian cancer, but below the belt health in general, and some of the symptoms that one may be experiencing, I think it's important for us to probably just run down a quick little list, list here for everybody. So this is actually coming from Mayo Clinic.
Okay.
Abdominal bloating or swelling, quickly feeling full when eating, weight loss unexplained. I always like to say unexplained weight loss. If you're trying to lose weight, probably not necessarily a red flag, but when you're dropping weight and you're not trying to, that is concerning from a clinical perspective. Discomfort in the pelvic area, feeling fatigue, i.e. feeling tired, back pain, changes in bowel habits, constipation is a big one, and the frequent need to urinate. What's interesting, I don't know, as both of you, as you listen to some of those symptoms, they probably call out to you relative to some other conditions.
Right. So as you're running down the symptoms, especially bloating, like when did we not feel bloated? Especially if we're on our menses cycle.
Yes.
So a lot of times, unfortunately, when ovarian cancer is discovered, it's usually have already spread.
Yes.
Which is unfortunate because the symptoms are really vague. Bloating, feeling full after you eat. Well,
constipation. You might have IBS. I mean, seriously, and I do think it's important too to say that some of those symptoms are also aligned to conditions like endometriosis, uterine fibroids as well. So, and you can have more than one etiology. You can have more than one disease process happening in the body, right? So when you find yourself in a position where you're experiencing some of these side effects, I think it's important for the audience to know that, hey, if nothing else, start taking note how long these things are lasting. When do they occur? Because I don't know, maybe you're constipated because you didn't get enough fiber in your diet for the past, 72 to 96 hours, potentially. But it's important to start, as OT Tricia said, start being mindful of what is actually happening and having that mind and body connection so that when you do connect with a licensed medical provider, you can articulate in such a way that will help them be able to discern what needs to happen next.
And you bring up a good point to be mindful, because if you have abdominal pain that is not relieved, right, with maybe a painkiller, an abdominal pain that is just nagging and will not go away, that is concerning.
Very.
That is, So that's being mindful that this pain is just constant and I just cannot get rid of it. That would be a concerning, symptom. But again, some of these symptoms, trouble eating or feeling full, like we said, or even the urinary symptoms, the urgency or frequency. Well, that sounds like a urinary tract infection, maybe. right?
That, or again, it could be uterine fibroids, or it could be a pelvic floor problem, potentially, in terms of the urgency. So, I mean, all of those things, you know, as those out there who are listening to this for the first time and maybe haven't heard it, because this is a conversation, I have to say, this ovarian cancer, I have a pair, as do you and OT Tricia. I don't know how often you've had conversations about ovarian cancer when you've had an annual exam. I personally
Mm-hmm.
can say that I have never had an ovarian cancer conversation. Sure, talk about breast cancer and how to do a self breast exam, but I've never had anybody talk to me about ovarian cancer. And hey, Jen, thank you so much for joining. And I'm curious for Jen and also for our other guests out there, Ms. Freba Freza, put in the comments, have you ever had a medical provider talk to you about ovarian cancer, much less what to look for? Um, and I'm just kind of curious to get a pulse for that, because
Yeah.
I don't think these conversations are happening. And when you are not able to have a conversation because you don't know what you don't
Right.
know, that puts your health at risk.
Absolutely.
Mm-hmm.
Absolutely. I am currently doing research on women's sexuality. And what I will say, there is a participant that I spoke to, and it is because of one of the genomic, like an ancestry type, what do we call these tests that you send away? DNA testing.
DNA test,
Mm-hmm.
yeah.
Right. In the male. Fortunately for her, it was, the result came back alarming to cue her in to do further genomic testing. She did have to pay the additional payment of whatever that was. However, she discovered that she had a gene mutation and she had early stage ovarian cancer.
Wow.
So that, just that curiosity actually saved her life. But again, if she did not do have the whatever genomic or DNA testing done, she would not have known. She was not having any symptoms, or was not tuned into having, or didn't know she was having any symptoms. What do we
Right.
think about that? I mean,
So it's also called, you know, in the therapy world here, when a client comes and they say, I have this going on, maybe it's urinary incontinence, it's important to look out for, you know, a differential diagnosis,
Yes.
such as ovarian cancer. Yeah.
right.
And so, you know, if you come and you have conservative management, it's important for viewers to know, if you come and you're seeking conservative management, let's say for some urinary incontinence, which I feel like a lot of women experience anyways, and things just aren't improving, it's important to check in, to know when it's to seek further advice, when you need to talk to a medical provider. And it's so important to advocate, because like you said, it's so easy for medical providers to just brush it off and say, oh, it's X, it's Y, it's Z, you know, come back again. Or it's important to advocate, check, you know, check to see what's going on.
You bring up go ahead, Jesse. No,
yeah, so what I was also going to point out, cervical cancer has a screening tool, which we know. But ovarian cancer, there is not a screen for ovarian cancer. Yeah. And I just read the numbers coming out of the American Cancer Society. And in this day and age, is, you know, like, why are we not having the conversation within our health clinics? And I don't even hear talks of maybe developing some type of screening tool.
Right. Right. So a couple of things
for ourselves as women.
So I wanted to touch on the advocacy piece and tie it into something that OT Tricia said, which is that differential diagnosis. So often when women go to the doctor and they talk about pain, we bring up pain relative to below the belt, it does not get taken seriously. And that's not me as a clinician saying that. That is documented data that has been studied. Our pain does not get taken seriously. But here's the thing that I'd like to impress upon anybody out there listening. When, first of all, you know your body better than anybody else. That's number one.
Number
So
one. Yes.
if you feel as though you're not getting the type of care that you need or you deserve, you can always go to a different practitioner. That's primary. Healthcare is a customer service business. But OT Tricia mentioned a great phrase, which is differential diagnosis. If somebody is giving you a diagnosis that you feel doesn't align to maybe what you think you have, because you have an education that backs up some of where you think your diagnosis is leading, or maybe you talked to somebody and they had similar symptoms and they said they had A, but the provider is saying you have B, you can always put a pause on the conversation and just simply say, what was the differential diagnosis that you used?
Yes.
When you are a layperson who is having a conversation and dropping a line like that, that will immediately cause any clinician, it should, cause them pause to go, oh, wow, this person
Right.
probably knows a little bit. So let me dive in a little bit deeper, pay a little bit more attention, and give them a little bit more information.
Absolutely.
So appreciate you sharing that, OT Tricia.
Mm-hmm.
Yeah, of course. And it's hard too. I mean, really quick, I just want to say, you had mentioned if your provider is not, and this is kind of unfortunate, if your provider is not, giving you the answers that you're looking for, to just get another provider. But it's hard. It's hard to find doctors. It's hard to make appointments. It's hard to get in. It's hard to make sure they take your insurance. And so, and it takes time too. And a lot of people, they're working all the time. And so women's healthcare, like when I say it goes under the radar, I mean, the roles that we take on as women, if you have a family, if you work, if you're taking care of, whatever, the house, healthcare is just going just below. It's not prioritized. So it's so important to prioritize your health. Find the doctors, take a little bit of time if you can, do the research, read your reviews, but it's like they don't make it that easy. It's difficult.
This is true. So are there ways, or are there tips that we can share on how women can actually make it a little bit easier to make health priority below the belt, which is what we're focused on, but also above the belt?
Yeah.
To make priority, health a priority, and then secondarily, how do you go about doing that? Hey, Miss Edith, how do we go about doing that? Because when we are not right from a healthcare perspective, to your point, OT Tricia, everything will fall to the wayside. So everything that gets in the way of the health, addressing the health, then falls to the wayside.
Absolutely.
So how can we address that and support our folks who are listening?
I was going to say, just to start off, is just maybe it's okay to actually look up maybe a symptom. It is okay to do that and just see what education comes out of it, so that you can be prepared to ask questions. You need to ask questions when you do go into the doctor, and you may inform the doctor, this is what I've been feeling. It's okay to say, I've also looked at, I try to align my symptom. Do you think that this could be a reason? And ask the doctor, why do you feel that way? What is your expert opinion about this? So that you can understand where they're going. Why do they see it in their view, so that you can be educated as well. So that would be my first advice, is to go in with a little bit of knowledge and always have questions.
Mm-hmm.
Yeah.
Perfect.
questions ready to, for you
Lined
to
up.
ask. Yep, lined up. So that
I
way you can
agree.
start a conversation and have,
Absolutely.
yes, absolutely.
And to OT Tricia's point earlier about swapping a physician for your current physician, I think some of the best ways to do that so that you're not having to go through a gazillion reviews on WebMD or whatever, ZocDoc, those different platforms, you can talk to your family, your friends and family, and ask them, who are they seeing? Do they like their doctor? Right? That's number one. If you've got somebody in your circle who actually likes and trusts their provider, that would be a great person to probably put on your top 3 list of folks to reach out to. But again, getting an appointment, that is hard. That is absolutely hard. When you talk about trying to get in to see a specialist, and the more specialized they are, the more of a challenge it is to get in. So, in asking those questions before you get in a huff, because I'm someone that will go to 0 to 10. So, I'll walk out and go, I'm going to get me another doctor, and I'll take the time to do it. But I absolutely get what, OT Tricia, what you were saying. Not everybody has that luxury to do that because they have other things going on. So there are some questions that you can ask and take a pause, take a step back and say, is there anything else that this could be? What about XYZ? We did not review my health history. We did not review my family history in this appointment.
Yeah.
I potentially, if we can't do it today, maybe I can come back and we can review my family history and take a little bit more deep dive, because I am concerned about no more than 2 things. 2 things when you go into that appointment. When you start getting into 3 and 4 things, that becomes overwhelming for anybody. And especially when you have someone who is literally bound in terms of how much time they can allot to a patient. So I think that that's key as well, to remember that when you're making these appointments, 2 things. That's it. Know what you want to take out or speak about and get out of that appointment. And taking photos of medications as well is really important. If you're not good at putting it in your phone, taking medications as well is also very helpful, because who knows, the symptoms that you're experiencing potentially might be related to what we call a concomitant drug interaction, which is just a drug to drug, or one drug is causing another drug to do something different where it leaves you not feeling well. So I think that's important. But I do want to get into why we have occupational therapists, Tricia, here, which is to talk about life post-ovarian cancer and some of that, the pelvic health things that people should know about.
Okay, so post-ovarian, so it depends on, I'm sorry if that's so dark. Okay, I just had to fix my lighting really quick.
No.
So post-ovarian, so it depends on the treatment. And I had spoken with Nurse Jessie earlier. If the ovaries are completely removed, you had mentioned the debulking surgery. So if ovaries are completely removed, now you have symptoms that could be similar to kind of like menopausal symptoms. Hormonal levels will drop. And when you have estrogen dropping, different things happen to the vagina. So you'll have atrophy of the muscles. You'll experience dryness, and of course that's going to affect sexual dysfunction. And when you have, a part of OT is meaningful activities, right? And so again, we don't really want to talk about sex because there's a stigma and there's something going on, but women need help in that area. And so we talk about kind of topical estrogen could be something that could really help when the muscles are atrophying. You have different exercises you can do too to make sure you maintain pelvic floor muscles. So just really quick, your pelvic floor is muscles, ligaments, and connective tissue that holds your pelvic organs together, which is your bladder, your uterus, and your rectum. Okay, so those are just the muscles down there. And then through occupational therapy, there's different exercises you can do to make sure you maintain that musculature. Okay, so when you have atrophying of the muscles because maybe the ovaries might be removed, you want to support whatever muscles you have down there post-surgery. And a lot of that has to do with, I mean, to be honest, a lot of it has to do with breathing. Really quick, I just want to go over one quick kind of exercise that all women can do. If you're laying down and you put your hands right around your hip muscles, or I'm sorry, your hip bones, right in your hip bones. So if you feel your hip bones while you're laying down and you make this sound like a snake, you'll feel your transverse abdominis muscles start to engage.
Okay.
And those are the muscles that wrap around the core. And those are the muscles that actually help to engage the pelvic floor muscles. Okay.
Wonderful.
So,
Are those called the sits muscles? Why is sits muscles coming to mind for me?
your sits muscles. Okay. So your sits bones are going to be your ischial tuberosity. So your butt
Okay.
bones. Is that something does that sound familiar?
Yes, it does.
Okay.
I'm sitting here, I'm putting my hands on my hips, and immediately sits muscles came to mind. That is great. Talk to us about Kegels. Everybody talks about Kegels.
Okay.
Yes.
So here's the thing with Kegels. Kegels are, if you're doing Kegels, chances are you're doing it wrong. So the way the pelvic floor works, it's a diaphragm. Your pelvic floor is essentially a diaphragm. You have 3 diaphragms. You have one in the pelvic floor, the one underneath your lungs, and you actually have one in your throat. Okay, and they all work together. So they flow together, kind of like they just flow together up and down. So when you inhale, things start to drop down, and when you exhale, things start to push up. At least that's what you want to happen. Okay, so when you're inhaling, you want to inhale into your belly, but not just your belly going forward. You want to inhale so your belly goes forward, your ribs expand out to the side, and you feel your back start to open up. And that's what's called 360 breathing. So what you have there is you have your pelvic floor coming down, you have your diaphragm coming down, opening up the lungs, expanding the lungs, pulling air down. So that's how you want to inhale. And as you exhale, you start to push everything up. So it's kind of, a lot of women don't breathe like this. So as you exhale, you want to feel your ribs start to come in. You want to feel your navel pull in and up as you exhale. And at the bottom of that exhale is when you would start to, essentially, you would feel kind of a pulling of your vagina. So you would Kegel, pulling in and up. And it's everything moving together, which is the proper Kegel. What normal Kegel, you think is just a squeeze,
Sure.
right?
Right.
So you can imagine if you have a bicep and you just squeeze. That's not, you're gonna have a hypertonic muscle. You know what I mean?
Yeah.
You're just contracting. The way you strengthen a muscle is you need full range of motion, right? So you need to open up and you need to come in for that contraction. So essentially, that is what you're doing with the breathing. As you inhale, you open up the belly, you allow the pelvic floor down to relax. And then as you exhale, everything comes back in, and then you squeeze up, almost as if you were kind of like lifting something up from your vagina.
Got it. So really quick, can we just take a moment to appreciate OT Tricia's guns?
Absolutely. As a nurse educator, I was educated on proper Kegels exercise.
So this makes me think of something that I say when my husband and I are working out and we're working abdominals, which is belly button to the spine.
Right.
I don't know. Should when someone is doing a Kegel, should they be visually kind of imagining stand tall, belly button to the spine to help with that, or not really? Is there a visual you can share with us?
Yes. Oh, yes, there is. So the best would be if you're laying down.
Okay.
So if you're laying down, you want to think, So instead of like, I just watched you say stand tall, and immediately I saw your chest kind of, you inhaled into your chest almost, and that's not what we want. So that will
Okay.
create, yeah, that'll actually create a shallow breathing pattern. So if you want to think about, if anything, you want to think, lay down, and as you inhale, you know, you would bend your knees. So imagine if you're laying down on your back and your knees are bent. So feet flat on the floor, knees are bent up towards the ceiling. And as you would inhale, you want to think about kind of your back pushing down into a bed or into the ground, right?
Okay.
So rather than you inhale and your chest lifts up, which is like a really how a lot of people breathe, which is, you know, you inhale into your chest and then your belly sucks in. We don't want that. Instead, what you want as you inhale, you want your navel to rise up, but you also at the same time want to feel your back kind of pressing into the ground. And as you
Okay.
exhale, then you would have navel into spine, and then you would like do your crunch or whatever exercise it is that you're
Got it.
going
Got
into.
it. This is so
Yes.
helpful
This is so
because I never
helpful.
knew that. I
Yeah,
don't know about you, Nurse
yes.
Jessie.
Absolutely. I mean, this is very helpful. Now, OT Trish, please let the audience know how they can find you.
So my Instagram is optimum_pelvis, and my personal Instagram is trishsun, SUN.OT. I'm also in Fort Lauderdale, in the Fort Lauderdale area, and yeah, that's about it. I
Awesome.
mean, I do home health, so private, and it's private practice, and I work in the home, and so that's it.
Fantastic.
This was wonderful. It's 36 minutes after. And Nurse Christy, while you were speaking, I thought about health literacy.
Yes.
You said something, and I forget exactly what was the phrase, but I immediately thought of health literacy when patients would come into clinics or, you know, healthcare setting, and do we take enough time to evaluate their health literacy?
The answer, my experience, because I don't want to speak for everybody, the answer is no.
Yeah. Yeah, that
No.
ties into, you know, what the reason why we're here, why we're doing this
Yes.
podcast, to help
And
just
tell everybody what health literacy is, Nurse Jessie, because I don't want anybody to think that that's an ability to read something health
right. No.
related.
So health literacy can be many factors that can contribute. And when I say health literacy, it is having the ability to read and write and understand the medical record. Or simply, I am being discharged by Nurse Christy, but I have a low health literacy. Christy is discharging me with all of these medical terms. Jessie, make sure you do your Kegel exercises 5 every night before you go to bed. I'm going to say, okay, thank you.
Yeah. And that happens often, and it happens really often with older patients.
Right.
And so there's this thing, to go back to the comment that I made earlier. Healthcare is a customer service business. You have earned the right to actually say, I don't understand that. I have questions. Can you share with me? Can you show me? If I get confused, is there a number for me to call and follow back up? Because I'm not real sure that I understand what's going on. The other thing too, before we wrap up, relative to health literacy, I think it's important to know that even if you are someone who is clinically astute, it's beyond crazy to think that you would know everything.
Correct.
I'm sure you've had experiences too where maybe you've had, let's say, a heart surgeon as a patient, but you're talking to them about maybe a GI issue.
Right.
There's a general knowledge there, but no one should be making an assumption that you know anything. And as such, you should never feel embarrassed to ask questions and or to get clarity,
Yeah.
because that will, that A can sometimes, oftentimes will save a life if it's not yours, somebody else, because you took the time to ask the question. But B, it makes things very clear when you go home, you know exactly what to do in order to maintain your level of health.
Beautifully said. Any last words from you, Nurse Christy?
Well, I will say, you know, it's September. It's Ovarian Cancer Month. I do believe it's also Prostate Cancer Awareness Month. So make certain for the men in your life that you're having a conversation with their below the belt health too, to get in and see the physician, and get that prostate looked at. But also next month is Breast Cancer Awareness. And when we think about below the belt, we don't necessarily associate both. You know, below the belt, what is vagina, the hormones associated with the uterus and the ovaries and all of that. What does that have to do with up here? And Nurse Jessie and I are going to tell you a lot. It has a lot to do with
a lot
that.
to do.
So we're going to touch a little bit on some of the hormones that people should be aware of relative to below the belt health. And then as we move into October, we'll deep dive a little bit into the breast cancer aspect of awareness and things that all of us as female, biological female, should be paying attention to. So appreciate that little plug. Allow me to make a little plug for our next session.
Absolutely. So we thank our viewers for tuning in to our podcast. I am Nurse Jessie.
Yes, I'm Nurse Christy. We have OT Tricia. You will be able to find her in our caption. So if you have questions for her, or you're in that Fort Lauderdale area, definitely you can reach out to her. And you can DM us if you've got questions and or topics. You can also email us at the Stirrup Sisters Podcast at gmail.com. But we want to hear from you. We are so appreciative that you joined us today, and also that you all engaged with us. So thank you so much. And we'll see you next time.
See you next time.
Thank you for having me.
Thank you. Bye-bye.
Bye-bye.